Hi, this is Dr. Bernstein with Dr. Bernstein's Diabetes University. Thanks for watching or listening. Before we start our current session, I have a few special subjects to cover, but the first one has to do with an article that was published in October 2018 in the Lancet Endocrinology Diabetes Journal. It was an evaluation of sulfonylurea drugs for type 2 diabetes, and it posed the question that's been around for maybe 50 years. Are sulfonylurea drugs still appropriate for the treatment of diabetes? And it was interesting that this was a very thorough summary of the many studies of the effects of sulfonylurea drugs. And it was evaluating only two things. Do they cause excess or severe hypoglycemia? And do they cause heart disease? Because these questions are brought up repeatedly or have been brought up over the years. And the conclusion was that there is no hard evidence that sulfonylurea drugs cause heart disease, and that the risk of severe hypoglycemia is limited to certain individuals, such as the very elderly, and so on. So if you select your patients appropriately, they were recommending that sulfonylureas are fine. However, in the middle of the article, which was quite long, there was an entire page listing the studies that showed that sulfonylurea drugs stop working after 1 to 3 years. And when they're combined with other drugs for type 2 diabetes, I'm not talking about insulin, but I'm talking about oral agents, it seems that all of them stop working together if they're used with sulfonylureas. Now, the logical conclusion to this is that sulfonylureas probably cause beta cell burnout, and that's why they stop working in 1 to 3 years. I think that there was one case of 4 years. Now, there have been a number of other studies that show that in animals, sulfonylurea drugs do burn out beta cells. And they even go through the mechanisms by which sulfonylurea drugs cause beta cells to self-destruct, called apoptosis. So if I were evaluating sulfonylureas, I would say if you expect the patient to live more than 1 or 2 years, 4 at the outside, don't give him sulfonylurea drugs because you're going to destroy his beta cells. Second subject. I've learned from several of my patients that the glucose solution sold for glucose tolerance tests called glutol works more slowly than the glucose shot that we purchase in the drugstores. It seems to be thicker and more viscous. I think it's a more concentrated solution because a typical patient will find their blood sugar goes up by about 13 milligrams per deciliter from a teaspoon, and a teaspoon of this stuff will raise about half as much for most adults. So if you have gastroparesis and want liquid glucose for hypoglycemia to work rapidly, use the more dilute solutions such as these little things. The glutol comes in a big bottle. One other subject that I'd like to discuss is a recent comparison of the different blood glucose monitors. The continuous glucose monitors CGMs. And this particular article is called Flash Glucose Monitors. And it's written by Dr. Nicholas B. Argento and published in Endocrine Practice in October 10th, 2018. This is a doctor who's a type 1 diabetic and has used a variety of continuous glucose monitors. And he compares them. And first of all, he makes a very strong point about the new flash monitors, such as the Freestyle Libre, that's the one. Freestyle Libre is becoming very popular, but there are major problems with the whole concept of a flash continuous glucose monitor. The classic monitor, such as the Dexcom, measures your blood sugar and gives a continuous readout on either a receiver, such as this little receiver, or on an iPhone, or perhaps a Samsung phone, versus the flash monitors, which will give a reading on your receiver if you flash it across the site. I have my monitor in my arm, so I'd have to flash it across the site and then read it. The problem with doing that, here's the number. The problem with doing that is that it doesn't warn you if you're not deliberately reading your blood sugar. If you're sleeping, or if you're busy doing something and not paying attention to your blood sugars, there's no alarm. But the classic Dexcom gives you an alarm. I have my Dexcom set to ring a fire engine bell, so it'll wake anybody up who's trying to sleep. And that's the appropriate application of a continuous glucose monitor, to warn you if you're going too low, or for those people who don't know how to control their blood sugars, if you're going too high. The flash monitors give no warnings. Now, I've also been able to get a comparison of the new G6 Dexcom with the prior model G5. First of all, the G6 is not sensitive to Tylenol. In other words, if the patient is taking Tylenol, you don't get inaccurate results. That was a problem with the G4 and the G5. Now, for the G6, Dexcom claims that you don't need finger sticks. That is not so. It is false. The FDA actually cleared the G6 with that claim, providing that the manufacturer claim accuracy of only plus or minus 30%. In other words, the FDA apparently said, if you will say that this device has an accuracy of only plus or minus 30%, wide range of inaccuracy, then you can tell people they don't have to do any finger sticks, because you're letting them know that the results are going to be, in all likelihood, inaccurate. So, as far as I can determine, the statement that the manufacturer is forced to make, that the accuracy is plus or minus 30%, is only because of this special FDA approval, that the G6 apparently, but I'm not sure of this, is not less accurate than the G5, which has a plus or minus 20%. Now, in my experience, which is only with the G5, if I have a steady blood sugar for several hours, it's going to be accurate within a few milligrams per deciliter. But my blood sugars are usually in the 70s, 80s, or 90s, in the narrow range. And in that range, I'm frequently right on the nose with the same, my meter reading is the same as the CGM reading. The receiver for the G6 is larger than the little receiver that I use for my G5, but so you can't put the big receiver for the G6 in a little pocket like I have in my shirt, but you can get a G5 receiver for the G6. So if you want a small receiver, you order a G5 receiver, which is also a G4 receiver. The G5 receiver measures 4 inches by 8 inches by 1/2 inch. I'm sorry, 4 inches by 1.8 inches, which would be about 2 inches. So 4 by 2 by 1/2 inch. So it's pretty thick. Now the introductory device that is used to apply the sensor to your skin is considerably simpler in the G6. It has fewer steps, and you can be simple-minded to apply it. The G6 I've found is a little too complicated, but the G5 is a little too complicated. The G6 is less complicated, but it gives a more powerful impact. So when you first connect the sensor to your body, you get a pow that some people won't like. So some people are going to complain about brief pain for just a second, just an instant, when they use the G6. That's about it. We've made as many comparisons as I could think of. Now back to down to the questions for the week. Before we start, I give you the usual warning that I am giving generic answers to these questions that might not apply to the individual who asks the question, because I have not gotten a medical history, have not gotten a family history, have not done a physical examination, don't know what other medications you're taking, etc. So there's a good chance that my answer will be, that the conclusion will be inaccurate, but the information I give you might be of general interest. My son is 6 years old and was recently diagnosed with diabetes 1. He also has protein in the urine and want to know if this is connected with his diabetes. I would ask your doctor to order a test called immunofixation urine. This is a test for other proteins in the urine beside albumin. Long-term diabetes can cause kidney damage that results in albuminuria, or albumin appearing in the urine. Diabetes does not cause globulins to appear in the urine. There are other diseases, a host of other diseases, that can cause globulins to appear in the urine. And since your son was only newly diagnosed, he's very unlikely to have diabetic kidney disease, but may have some other reason for having globulins in the urine. So I would recommend that this be checked. This is another son. My son's blood glucose levels look like an EKG reading after he eats. That means up and down. He is on the Omnipod and the Dexcom G6. How do we get his under control? He is up to 300 plus, then down to 50. A1C is 8.4. Well, what's happening here is what I warn in my books and have warned in my Diabetes University and have warned over and over: don't use insulin pumps. There's no way to get, that I know of, to get accurate blood sugars from an insulin pump. We've gone through all the reasons. The game plan is to get hold of my book, Diabetes Solution, and follow the guidelines very, very carefully. If you want some encouragement or to learn of other people's experience doing what it says in my book, go to Type 1 Grit, type ONE Grit on the internet, and you could see what other diabetics are experiencing, including many children, by using a CGM. The G6 would be fine, but not hooked up to an insulin pump. And I might add that doing what it says in the book is not the easiest thing in the world. It's a lot of work. It's a very restrictive diet, but it generates survivors, people who don't get the complications of diabetes. I am 62 and in good health. My blood pressure is now being medicated. I've been type 1 for 31 years. My GP says that my blood pressure goal is 130/90, but I know that that is too high. Could you please confirm that the goal should be 120/70 as written in your book? Well, first of all, I doubt that I write in my book that there's a fixed blood pressure for everybody. It depends on the individual. And right now, there's controversy going on even amongst the various professional organizations, American Heart Association, American College of Endocrinology, etc. Different associations are recommending different blood pressures. And the different blood pressures are recommended for different ages. So it's pretty complicated, and it probably does not have to be in a very precise, narrow range. So, for your information, normal blood pressures tend to run below 120/80, but 120/80 itself is considered normal. One other thing that's significant is where and when the blood pressure is measured. Blood pressure is different at different times of the day. As I recall, it's maximal when you first wake up in the morning. If you go to the doctor's office and he checks your blood pressure when you first come in, it's likely to be higher than if he checks it after you've been resting in the waiting room for a while. Or if you're waiting too long, your blood pressure might come up and be artificially high. So home blood pressures may be desirable, but you have to make sure that you have an accurate machine, not a fingertip machine, not a wrist machine, but one with a cuff that goes on the arm, and one that's been shown to be accurate. So there are lots of questions. It's not that simple. This concerns a high BG reading during and after exercise. I'm a 58-year-old woman with type 2 diabetes. I take metformin 3 times a day with meals and have an A1C of 5.8. I play tennis and lately feel pretty bad while playing and afterwards. Smells like low blood sugar. I took my BG last week 30 minutes after playing, and it was 230. Wow, so it's not a low blood sugar, it's a high blood sugar. Normally, I keep it under 120 even after eating. My primary care physician refuses to refer me to an endocrinologist. She says my BG monitor must be broken. Can you help me? Well, first of all, I recommend that you have an accurate blood sugar meter, because there are many meters that are inaccurate. And we've, at least for the time being, been recommending the Freestyle Freedom or the Freedom Light. I've seen several meters that can give you a reading of 200 when your real blood sugar is 80. So you must use an accurate meter. Then I would recommend that you check your blood sugar routinely before and after exercise. And if it routinely goes up, you show the data to your physician. And if your physician is not willing to listen to you, you might want to find a physician that's more reasonable. I usually recommend that people have a primary care physician rather than endocrinologists, because most endocrinologists subscribe to the professional guidelines for treating diabetes, which mandate high blood sugars. So if you don't want to have high blood sugars, you're probably wiser to get a kindly family care doctor. You could check whether your friends or neighbors have a local physician who might be more cooperative. If your blood sugars do go up after exercise, your physician can do what I did with one patient today and with another patient last week. I have them take a drug called rapid-acting propranolol, a beta blocker, 1 hour before the exercise. And that usually prevents the blood sugar increase from exercise. What did you eat yesterday for your 3 meals, and how many calories? I am 73, diagnosed 7 years ago. My latest A1C is 11.3. I think you should be more concerned with your blood sugars. 11.3 A1C is an average blood sugar of about 300 milligrams per deciliter. That's pretty darn high. You'll feel a lot better with normal blood sugars, so I suggest you read my book, Diabetes Solution, and not worry about what I'm eating. You should worry about what you're eating. What is the preferred pathway to manage diabetes during pregnancy if this is gestational diabetes? She says she was pre-diabetic before pregnancy. The preferred pathway is to have normal blood sugars for 3 months prior to pregnancy, and then after the first trimester, blood sugars in the 60s. And I certainly urge you to read my book, Diabetes Solution. And if you live anywhere near the West Coast, you might want to visit the Samsung, SAMSUNG, Research Institute, where they treat diabetic pregnancies and seek normal blood sugars. It is the elevated blood sugars that cause the abnormal fetuses that are frequently found with pregnancies from diabetic mothers. What is your opinion of inulin? I've purchased a sweetener called Cocoa Monkey, and inulin is the main ingredient. I did a quick search online and found that it is a type of fiber. Well, there are many brands of inulin. Typically, it has 5 calories per teaspoon, which is about 1/3 of that of sugar. So it, even though it's a fiber, it can raise your blood sugar, but not very much. 1/3 as much as table sugar. I wouldn't use it as a sweetener because it is digestible and does slightly raise blood sugar. By the way, the cocoa monkey also has coconut water in it. What is your opinion of pioglitazone? That's Actos. My primary care provider prescribed it for me, but when I read the data sheet that the pharmacy gave me, I got wary and just took one pill. Instead, I started watching my diet and lowered my blood sugar to the point where I got one reading to 91. Well, first of all, you should read my book. That will tell you how to control your blood sugars, and it'll tell you about diet and exercise, etc. The Actos, I've used it in many patients, but it frequently causes edema, fluid retention, which is not a desirable condition. It's tolerable but not desirable. There's a sister drug called Avandia that is in a similar category, but in my experience causes less edema. So I've used Avandia to help lower blood sugars when diet and exercise and weight loss have been inadequate in type 2 diabetes. But just an hour ago, I was speaking to a patient of mine who's taking Avandia, very effective, but she has 4+ edema in her legs as a result. So I have to discontinue the Avandia. She's been taking glucophage, which is metformin, and the metformin is always the first choice for almost everybody except if they get diarrhea. So the metformin comes first, Avandia second for those people who do not get edema. There are other potential hazards from the thiazolidinediones, as these drugs are called, such as bone fractures, macular edema, and so on. But those are rare. My main concern is edema in the legs, pretibial edema, which is very easy to measure. So I say, read my book, and I'd certainly take glucophage before I would take Actos, but there are problems with diarrhea from glucophage, so you have to use it in a certain way, and that's all described in my book and in my videos. What is your take on the new fad kombucha? Is it a no-no food? It's fermented glucose, and the residual amount of glucose that remains in the product varies with the source. So it's a source of glucose, and how much of that is in there, you don't know unless you want to test it. Now, you could test it by using a Clinistix, and you could give it a try and see how much glucose is in it. I wouldn't recommend it. Is there a preference for specific fast-acting insulin. Again, read my book. There are, as far as I can tell, 4 different fast-acting insulins on the market. There's regular insulin, also called crystalline insulin. It goes under the names of Novolin R or Humulin R, and overseas it might have other names. That's the insulin that nearly all of my patients use for covering meals for type 1 diabetics. There's Novolog, which a lot of the insulin pump makers use, and which I have very few of my patients taking. There's Humalog, which is the most rapid acting of the insulins. It's too fast for covering most meals, but some insulin-resistant patients of mine absorb insulin slowly, so we may give them Humalog. Also, if I or a patient of mine wants to rapidly reduce an elevated blood sugar, we may use Humalog, but Humalog is twice as potent as Novolog. Twice as potent as regular, so it's harder to measure a dose that'll have a small effect. 1 unit of Humalog will lower my blood sugar by 100. So I'd have to use diluted Humalog, and many of my patients use diluted Humalog for rapid blood sugar reduction. Then there's Apidra, also generically named glulisine, made by Sanofi, and that's faster acting than regular, but slower acting than Novolog. So the sequence of speed of action is slowest regular, next Apidra, next Novolog, next Humalog. And the most appropriate for food for most people is the regular. I'm in a process of switching from Levemir to Tresiba. Levemir is a long-acting insulin. Tresiba is a long-acting insulin. Tresiba is longer acting than Levemir. What do I do with the Tresiba? Okay. What I tell my patients to do is, in theory, you'll need approximately the same dose. But because the Tresiba is longer lasting and spread over a longer period of time, maybe you might need a little slightly larger dose. So if a person were taking, let's say, 6 units of Levemir twice a day, I might say they may really need 6.5 or 7 units of Tresiba, but you can't measure half units on Tresiba ordinarily. But for a trial, I'd say take less Tresiba and see what happens, because we don't want you getting hypoglycemia, especially overnight while you're sleeping. So if you were getting 6 units of Levemir twice a day, I'd say start off with an experiment with 5 units of Tresiba twice a day, and be sure to take it initially on a rising and at bedtime, not every 12 hours as many doctors recommend. You want to be able to cover the dawn phenomenon in the morning. Now, if you're a full type 1 diabetic, there's a good chance that the Tresiba will not last at extra strength long enough in the morning when you get up to cover the dawn phenomenon. At least it doesn't for me. So I take my evening dose at about 10 p.m. And at about 4 a.m., I take my morning dose so that it'll be working actively when I get up at about 7 or 8 o'clock in the morning, and will overlap the evening dose that I took. So I have 2 doses working in the morning, covering the dawn phenomenon. Now that takes a sacrifice. It happens that I frequently wake up within an hour of 4 a.m., so it's not that inconvenient for me. But for many of my patients, it is inconvenient, and they have to set an alarm. Otherwise, many of these patients will wake up with a high blood sugar and have to take a half unit of Humalog on arising, or maybe some diluted Humalog on arising. It's complicated. My husband has type 2 diabetes and follows a low-carb diet. He developed diverticulitis and was told by the nurse practitioner not to eat low-carb, but instead follow the BRAT diet and also stick with pasta, rice, and chicken, which he referred to as real food. What are your recommendations for a diabetic with diverticulitis? Well, first of all, the guidelines for diverticulitis are to eat more fiber, not less. And the foods she's recommending are not high fiber foods. She's talking about pasta, rice. Those are starchy foods. So she's recommending just the opposite of what a diabetic should eat. Read my book and it goes into all the details, or watch my videos. Our daughter is type 1, 16 years of age, and following the diabetes solution protocol after reading your book. Do you have any tips on how to avoid the daily post-weight training spike in her blood sugars? Well, we've talked about this before, and that is, well, there are 2 things. First of all, if she's doing her exercise in the morning, she should move it to more than 4 hours after arising, so somewhere around midday, afternoon, or evening. That's the most common cause of high blood sugars after exercise, exercising during the period of the dawn phenomenon. If she's exercising in the evening and blood sugars go up, follow my prior recommendation for propranolol, namely 10 milligrams of propranolol, beta blocker, rapid-acting propranolol, an hour before exercising. What about juicing? Do you think I should juice with 100% vegetables or no juicing at all? This reminds me what happened when I first started in practice. In those days, I would negotiate a meal plan with a new patient, and I was anxious for them to get vegetables. And I said, in those days, the ADA was pushing vegetable juice. There was one on the market. I haven't seen it around lately. It was called the V8, V like in vegetable, V8 juice. And I suggested that patients drink V8 juice and see how much it raised their blood sugar and cover it with insulin as they would any other vegetable. The trouble was that they were complaining that their blood sugars would go very high, very rapidly from a small glass of V8 juice. So I stopped taking the ADA's advice on dietary recommendations. Don't juice your vegetables. If you have gastroparesis and may need a semi-liquid diet, you could put your vegetables in a blender. Don't blend it long enough to create juice, but even the juice might work slowly enough with you that you don't have problems if you have severe gastroparesis. That's something that has, again, involves trial and error. You have to do it and see what happens. Type 1 for nearly 50 years. I'm on a low-carb diet and occasionally experience pronounced rise in glucose between 5 and 8 a.m. without having had any calories for 8 hours. This only happens about 40% of the time. Is there anything I can do for this? Well, if he's had, or she has had diabetes for 50 years, my guess is that it's been poorly controlled for most of that time, because my book has only been around 30 years, and you likely have gastroparesis as a result. And if you have gastroparesis, your dinner emptying is going to be unpredictable. Some days your dinner may end reasonably rapidly within a few hours. So if you're going to go up after dinner, you'll see it. Or if you're going to be level after dinner, you'll see it. But some other days, it might empty very slowly. You'll go too low after dinner. You'll take glucose or something else to raise your blood sugar to normal. But then your stomach will do most of the emptying while you're sleeping, and you'll be high in the morning. So in your case, the most likely thing is gastroparesis. And you have to follow my book. There's a whole chapter on the treatment of gastroparesis. It could be the dawn phenomenon, but the dawn phenomenon is usually very consistent. People may wake up high every morning. It's not likely that they're going to just wake up high some mornings. So I would suggest, first of all, that you get an RR study done to find out if you have gastroparesis, and then take a look at the book and read the chapter on gastroparesis. But read the whole book if you want to be able to really control your blood sugars. What can it be done about very severe neuropathy pain? Well, the ADA recommends all kinds of painkillers, none of which get to the underlying cause of the pain. I've read about intravenous alpha-lipoic acid for treating neuropathic pain. There are 1 or 2 reports of studies on 1 or 2 patients, and the effect is questionable. Neuropathic pain goes away when you have normal blood sugars. It doesn't go away instantly. The nerves have to regrow and heal, and it could take months. Neuropathic pain can also be caused by improving blood sugars if you first have numbness. So let's be talking about the lower extremity, which usually is what has neuropathic pain. So you have feet that are numb, and they've been numb for a long time, and now you finally normalize your blood sugars, and now the feet start hurting. And as one patient of mine once called it, he used the term lancinating pain. Severe, unbelievably severe pain, but he knew that the nerves were healing, and that if he waited a few more months, the pain would go away, and that's what happens. So the best way to treat neuropathic pain is to have normal blood sugars, get your blood sugars absolutely normal, say in the 80s, and wait a few months and put up with the pain, knowing that it's going to get better. The ADA recommends some antidepressants, GABA, all kinds of things that have minimal effect. Many doctors are recommending opioid painkillers, etc. And all I do is recommend normal blood sugars, and it works. What do you think about Denise Faustman and the BCG vaccine? Well, Denise Faustman of Harvard has been claiming, I believe for 20 years, maybe longer, that she has a cure for diabetes. And her latest approach is to give what's called an adjuvant. This adjuvant was used with a tuberculosis vaccine many years ago to make it more effective. She published in the journal Science a number of years ago. I'm sorry, I forgot what she published, but she published a study claiming cures of diabetes, and then other people published their studies in the journal Science, claiming that they found no results in their attempts to duplicate her studies. So right now, I don't see anything. Maybe she has something, but this has been going on a long time. What is fatty liver disease? How do you know if you have it, and what can you do to avoid it or to cure it? Well, I had fatty liver disease when I was in my teens until I got my blood sugars controlled when I was in my late 30s. First of all, the liver, my liver, hung down below the right costal margin. That's the bottom rib. It's called the costal margin. And it was about this distance, these 4 fingers breadth, below the costal margin. It was huge. And if I pressed on it, it hurt. So I had a tender fatty liver. I've seen fatty livers in many of my brand new patients when they first come in here. And what makes it better? Normal blood sugars. It took about 3 years after I normalized my blood sugars for the fatty liver to disappear, and there was no way that I could cause any pain by sticking my fingers up under my ribs, etc. So you can actually feel it. You can feel if it's tender, and any doctor can make the diagnosis. Now, the diagnosis is for an enlarged liver. Is it diabetic fatty liver? It's the most likely thing if you're diabetic and have an enlarged liver. You could be an alcoholic and have an enlarged liver from the alcohol. You could be taking some medications that cause an enlarged liver. But the most likely thing if you're diabetic and have an enlarged liver is the fatty liver. Would you agree that there could be a cure for diabetes, albeit would not be promoted due to the loss of profit and probably most importantly, people losing their livelihoods as well as science losing talented people? I doubt it, but it's a possibility. I can see, for example, a drug company stumbling on a cure and then terminating any further research because they're making a lot of money on a drug to treat it. But I doubt that that's going on. There are, however, a number of organizations that are soliciting funds for a cure for diabetes, and not necessarily spending the funds on seeking a cure. After running 5 kilometers, my blood sugar levels rise slightly by 1 or 2 millimoles, which is 18 to 36 milligrams per deciliter. Is this normal? I don't think so. However, if it's in the morning and you're type 1 diabetic, I can certainly see that possibility. And if you're running with a high blood sugar to begin with, that causes insulin resistance, and you may go up even higher later on. So those are the two possibilities that I can think of. Ordinarily, 5 kilometers is not a great distance. It's about 4 miles. If you are well controlled, that is, usually have normal blood sugars, are taking your usual amounts of insulin and doing your usual eating, and you run 4 miles, I would usually expect your blood sugar to go down, but not in the morning. I had one patient, one of my very first patients, would run 5 miles every morning, and he had to take 2 units of regular insulin to prevent a blood sugar increase from the run. 48 years old, type 1. 15-year gratefully following your program. I have evening lows when on long-acting insulin, Tresiba, Levemir, Lantus. So I've been using NPH at 10 p.m. and 5 a.m. I recall that you mentioned that it's possible to develop an allergy to NPH. What would be the symptoms of an NPH allergy? And if developing one, how would it be possible to desensitize in order to resume NPH use? Well, I don't think I ever picked NPH as a target for allergies. One can be allergic to insulin, usually not human insulin, more likely the old animal insulins, and but the only human insulin that we have available is regular insulin. The other modified insulins, like Humalog and Novolog, et cetera, Levemir, you name them all, none of them are molecularly the same as human insulin. So it's possible to be allergic to any of them. The NPH in the old days was a target because it contained a protein called protamine, which in the very old days was derived from whale sperm, and you could be allergic to protamine. So how do you know that you're allergic? Usually people had inflammation at the injection site. I can only remember one person in my entire practice history who had insulin allergy. She was a teenager, and this occurred about 30 years ago, and she required about 200 units of insulin per day. So she was, and in those days we did not have human insulin. So I desensitized her, and it worked. She ended up with something like 25 units a day. What we did was we gave intradermal injections of very dilute insulin. So I think we started with insulin diluted with insulin diluting fluid, and there is diluting fluid for NPH, but there's not diluting fluid for any of the long-acting insulins. We gave 100-to-1 dilution, so 100 parts of diluting fluid to 1 part of insulin. We injected it into the skin of the forearm over here intradermally, so it was barely under the skin. It made sort of a bubble. And we waited, I think, an hour to see if there was any reaction, if the skin got red around it. And if it didn't get red, we would then inject a 50-to-1 dilution. And we do this, it took all day to do this. Every hour, she'd get another injection that was more and more concentrated until we finally gave her an injection that was full strength. It was, we may have injected a half a unit. And lo and behold, no reaction. Now, had she gotten a red reaction from one of the dilutions, we then would have gone backward to an intermediate between the prior 2 dilutions before we progressed to more concentrated. And that's how it works. And it was great. It worked right away. I'm a type 2 diabetic with 5-year history. My A1C is controlled at 5.0 for at least 3 years. My BUN is 26 for the last 2 years. My body mass index is 18.4, so he's probably of about normal weight. So I am a bit careful with protein. I don't know what that means or why. I am trying to get pregnant. Is there any adjustment I need to do for my diet while trying to get pregnant and during pregnancy, like the amount of carb, protein, and insulin requirements? Well, I would give this patient the same recommendations that I gave to the other person who wanted to get pregnant. First of all, her BUN, which is slightly elevated, perhaps for her age, could be slightly elevated just from exercise. So if she's exercising every other day, her BUN will be elevated, especially lower body exercise. That's not caused by protein. If you want to know how your kidneys are, you should be checking creatinine or cystatin C, not BUN. You should be looking at blood sugar, not protein, as a cause of kidney disease. Protein does not cause kidney disease. I would think that, like the pregnant women I've treated over the years, you do better with a high protein diet, and at least until the 3rd trimester, you should be building protein in your body and in your fetus while it's growing. And in the 3rd trimester, you don't have to cut it down, but you don't need as much as you would in the first 2. And also you might contact if you live near the West Coast, contact the Samsung Research Institute. Diagnosed pre-diabetic 3 years ago at 57. Very light gestational diabetes at 23. Father, grandfather diabetic. No medication during 3 years, but on your diet. My A1C ranges from 5.2 to 5.5. 5.5 is an average blood sugar of about 120, but it could be varying up and down around that. Doctor says, no worries, you are in normal range, but your book says otherwise. Your book though does not address the issue of should you take medication to lower it further, even though by conventional definitions you are in the normal range. Well, my feelings are that you should, first of all, I would not like a 5.5 for myself if I had a choice. I would like to get under 5. And I would use medications for myself if I had if everything else failed to work. Now, that means weight loss if you're overweight. It means a very low carbohydrate diet, but getting enough vegetables, at least a little bit of red meat a couple of times a week, in order to get all the necessary vitamins. And and strenuous exercise, muscle building, plus cardiovascular exercise, if all these things put together wouldn't get my blood sugar under 5.5, I'd probably start taking glucophage, which is metformin. And I would start with the XR, the slow release. I'd start with a small dose. I'd start it after a meal because it might cause diarrhea if you take it before a meal. And all the guidelines for using metformin are in my book. That's what I'd be doing. Well, that's it for tonight. Thanks for listening and watching. Our next teleseminar is going to be on Thursday, December 26th, the day after Christmas. I look forward to seeing you then. Please join me, and happy holidays.